My honor to introduce Emily and Jordan. So, Emily Arkin is a registered dietitian specializing in eating disorders, gastrointestinal disorders, and weight-inclusive care. Her group nutrition practice, RD Emily and Team, is based in Washington, D.C., and serves the greater DMV area in North Carolina. She's a member of the Dietitians in Gluten and Gastrointestinal Disorders, a dietetic practice subgroup within the Academy of Nutrition and Dietetics, where she contributes to the Disordered Eating Working Group that develops medical nutrition therapy resources for GI dietitians who encounter eating disorders in their practice. She has also previously worked in PHP, IOP, higher levels of care for eating disorder treatment, and is involved with the International Association of Eating Disorder Professionals, the International Federation of Eating Disorder Dietitians, and Eating Disorders Coalition and Project HEAL. Emily has presented on behalf of AND, its DC and Maryland affiliates, IAEDP, and the Multi-Service Eating Disorders Association, as well as primary care and therapy groups. She is also the co-author of the new textbook, Comprehensive Nutrition Therapy for Co-occurring Gastrointestinal and Eating Disorders. Jordan Shapiro is a physician board certified in internal medicine and gastroenterology with expertise in disorders of gut-brain interaction, the overlap of eating disorders and GI, pelvic floor disorders, and the transition from pediatric to adult care. Dr. Shapiro did his medical school at the Medical College of Wisconsin, residency at University of Cincinnati Children's Hospital in internal medicine and pediatrics. He worked as a complex care special needs pediatrician at Texas Children's Hospital and completed his gastroenterology and hepatology fellowship at Baylor College of Medicine in Houston, Texas, where he was a clinical research fellow earning an MS in the clinician scientist training program at Baylor College of Medicine. Dr. Shapiro has authored many peer-reviewed articles, textbook chapters, and is a co-author of the new textbook, Comprehensive Nutrition Therapy for Co-occurring Gastrointestinal and Eating Disorders. In addition, he has been a guest on several podcasts. Dr. Shapiro founded Gentle GI, a trauma-informed GI practice in Houston, Texas in 2024, and continues to provide locums coverage in Durango, Colorado, 1 week a month as his practice grows. And with that, over to you both.
All right. Thank you so
Thanks.
much for having us.
Thank you for having us. Looking forward.
Yeah, we're really excited to present on this topic because it's something that I think is hitting a lot of people's practice, this question of bloating and distension and sort of what's normal. And so we wanted to take some time to talk a little bit about this topic with a sort of special eye for eating disorder risk or risk of disordered eating, just because when people are noticing a possible GI issue, often the first thing that they're going to, or the first thing that doctors sometimes recommend, is like cutting out food. And that can sort of start a slippery slope. So Jordan and I don't have any disclosures to share. This sort of summarizes a little bit of what Jocelyn mentioned. We are the proud co-authors of a textbook called Comprehensive Nutrition Therapy for Co-occurring Gastrointestinal and Eating Disorders. And so this is where I had actually attended at least one of Jordan's webinars way back in the day, but we sort of re-met as colleagues on this project, and we're really excited to bring that to the world. So we have a couple different objectives today. The first is to develop an approach to identifying causes of bloating and make sure that we're sort of working through that systematically. The second is to be able to name alarm symptoms that would suggest that a more immediate gastroenterology referral is necessary. Third, to identify 2 interdisciplinary referrals that can be made for chronic constipation. And fourth, to describe the risk of undertaking elimination diets, as well as alternative therapeutic approaches in those cases. So first, just a few words about bloating versus distension versus even fullness. The global prevalence is estimated to be about 18%, but often clients are going to come in just using the phrase bloating, and we want to make sure that we're understanding what they mean and encouraging them to sort of use like the appropriate term, because not all of them are aware of what distension is. So bloating is an internal sensation of pressure. A lot of clients will describe feeling as if they're sort of like filled up with a balloon, and if they could just pop that balloon, they would feel relief. Bloating is not necessarily visible to the outside. It's this internal sensation. Distension is visible from the outside. So this represents an actual change in abdominal girth. And so this is kind of when things are sort of sticking out more than you would expect them to. And someone can experience bloating or distension or a combination of both together. So on the right side here, I have a couple of photos that honestly I just clipped from social media using, I think, like hashtag bloating. And the bottom example is like a really sort of obvious example of distension. We see sort of a before and after where someone has like a really significant change in abdominal circumference. They may also report bloating, but we wouldn't know that from a picture. The photo up above is a little bit harder to suss out, and this is where we kind of need to have a radar up for if people have kind of unrealistic expectations of what fullness looks like and feels like. This is not as obvious of an example of distension, and so with this person sort of labeling this as bloating or as problematic, I would be curious, is this just what your stomach looks like after eating? A lot of people, sort of with the advent of social media influencers that are sort of like all showing off these sort of like flat tummies. A lot of people kind of have this inappropriate expectation that like they should also be somewhat concave after eating, and that's just not the case. And so, in kind of assessing maybe a little bit of that dysmorphic presentation, you may want to listen for if there are other places where reality is not quite lining up with what the client is describing, where like, they may be showing no distension whatsoever, and they're like, look how big I am, I'm huge. So it gets a little sticky navigating all these, but we want to make sure that at the very least, we're sort of going through terminology with clients and saying like, okay, bloating means internal pressure. Is that something that you experience? Distension means, an actual sort of change in that abdominal girth. Is that something that you're experiencing? So I'm going to hand it over to Jordan to briefly go over some of the major causes that we see with bloating.
We won't go through all these, don't worry. Um, One of the things I just wanted to comment on the prior slide too is just taking into account. So in Spanish, there is no word for bloating, and so a lot of patients will come in actually, saying I have gastritis or gastritis or inflammation, and so I think it's just an interesting point to make that from different cultures, the terms that we use and we're trying to like pin down like which is it or is it both? There are many cultures where those may not apply, and so just a point that I learned just a couple of years ago that can be important to know.
I did not know that. I'm sure that comes up in Texas.
It sure does. Um, so we won't go through all these. I think the important thing to take away from this is there are a lot of causes of bloating. I will often use the analogy of a cough. So patients come in with coughs all the time, and there's not like a medicine for cough because the question is what's causing the cough, and it can be really hard to find the cause of that. And people will go out, and we get a URI or something, an upper respiratory infection, people will just buy like 15 over-the-counter things and think like maybe I'll get the cough to go away. And it often doesn't work. And I think bloating is similar. We're all looking for that one thing. And sometimes we can identify a single cause or a group of causes that likely led it to happen. That's often the goal. But it can be challenging. And sometimes I'll just let patients know, like, I know these are really common symptoms. And yes, I'm a gastroenterologist, but it's actually one of the things that I think can be the most frustrating for patients and sometimes doctors to work through. I'm going to start the picture on the right briefly. It's a little blurry. I won't go through all those things, but I think it's important to remember that the gastrointestinal tract is a tube. It runs from the mouth to the anus. When we get into the guidelines from the AGA that we're going to go through a little bit stepwise with you, you'll see that we start at the bottom because if there's something at any point in the tube that's not functioning normally, that can certainly cause gas and bloating and distension. And so it ranges from food to, and certain sensitivities to types of food, to the gut nerves just being too sensitive, to overabundance of bacteria that are forming for various reasons if things aren't moving through the gut. And a lot of times I think it's important to note that like the majority of bloating cases are not from something life-threatening. You'll see in the list here things like cancer and surgery in the past, and um, most are not from that. So it's our job to rule a lot of these things out and try to identify what's going on in a patient. The last point I'll make is just this is lumped on the left side into organic etiologies, meaning like there's something you can put a finger on and see on an endoscopy or a colonoscopy or a CAT scan. Um, Disorders of gut-brain interaction is probably where most patients' bloating fits into. And these are syndromes where there's hypersensitivity of the nerves of the gut, or things are moving too fast or slow, or there's an overgrowth of certain types of bacteria. And most of these are things, with a few exceptions, with some of the pelvic floor dysfunction testing we can do, where you can do all the tests under the sun and you're not going to find any abnormalities. Doesn't mean that the patients don't need validation that I believe that you feel this, because I think a lot of them get gaslit by providers who, the CAT scan and endoscopy are normal, and they feel really bad. Um, and it also doesn't mean that just because we can't see it, that we can't have a best guess as to what's going on and try to make things better. So.
Yeah, so a couple of years ago, the American Gastroenterology Association released a clinical practice update that sort of has to do with belching, abdominal bloating, and distension. We are going to focus primarily on the flow chart that they offered for clinicians for abdominal bloating and distension. So this is geared more towards gastroenterologists and that type of audience. I think most of our attendees are probably dietitians, and so what we wanted to offer was kind of almost an annotation of this flow chart so that it feels more useful for RDs in the room. And so you'll see that it sort of starts at the top left, and you're sort of ruling things out, or following kind of a treatment algorithm here. The first sort of modification that we're going to make, just because we want to make sure that clients are sitting in front of the right provider, is assessing for alarm symptoms, because this might sort of change whether it's appropriate for them to be working outpatient with you, or maybe they have more immediate needs that sort of need to get looked at. And so Jordan's going to share a bit about that.
Yeah. So I think if there's anybody, sometimes you just get some pun intended, but also a gut sense that there's this person just seems sicker. I think over time in our practices, sometimes you walk in the room and within a few minutes, just something doesn't feel right. I would just honor that. The worst case scenario is there's a brief detour and they get some evaluations and they come back. But some of the major symptoms to think about are if somebody has recurrent or intractable nausea and vomiting, it's, every day, and there's not much that helps with it. Unexplained anemia, specifically iron deficiency anemia. So the best marker for that is a ferritin. All the other iron and percent saturations are kind of distractors, but we base that definition on a diagnosis on is what the ferritin level is, if it's less than 30 or 45, depending on it. But that is, unless somebody has menstrual blood losses or some other source of loss, which we always need to think about, there can be more than one source of blood loss. Typically, if someone's iron deficient and even alone, or iron deficient and anemic, we need to think about blood loss from the gastrointestinal tract as a potential source. And in males, we go straight to a GI evaluation because obviously they're not having, I should say, with I want to be appropriate, like, yeah, yes, thank you. So hematemesis, vomiting blood, or if somebody's, I would say the other end too, has visible blood loss, that's a problem that needs to get evaluated. Weight loss, which is usually defined in most settings as more than 10% and unintentional. Obviously, in the eating disorder community, that's sometimes a little fuzzy to tease out and take some time. A history in the family of GI cancers or malignancies, inflammatory bowel diseases like Crohn's disease and ulcerative colitis, or celiac disease, and then ascites or jaundice, things that might point to liver condition, like a liver abnormality. Sometimes the abdomen distends and it's not just gas and air or displaced organs, that's actually fluid building up, which can happen in a variety of settings. The most common being cirrhosis, or it's like end-stage liver disease, some kidney diseases, heart failure. So not everything that distends or feels bloated is a GI issue, and we need to just keep that in mind.
So if none of those alarm symptoms are on the table, it's appropriate for the person to be sitting across from you. Then we want to go back up to kind of the top of this algorithm and ask, is constipation present? And the reason that this shows up very early on is because when you have a colon that is sort of backlogged with stool, the pressure from like the dilation of that colon and its contents, like that can create all these other symptoms. We might see early satiety, worsened heartburn, gas, bloating, distension. Sometimes the pressure is so intense it's sort of tripping over into abdominal pain. Sometimes you just get irregular bowel movements because there's sort of this like back and forth between constipation and then overflow diarrhea. So it can create a pretty messy picture where it's hard to assess for other things until we know that this person is emptying fully. So when we are suspecting constipation and kind of working through possible treatments for that, I like to sort of think of almost like a treatment ladder where we're starting at the lowest rungs of the ladder and working our way up if we're not sort of getting the results that we want. The lowest rung of the ladder is what I refer to as the 3 Fs. So fiber, fluids, and fitness, or basically exercise, moving your body. For people who have blip on the radar constipation, or just like maybe it pops up when they travel, for example, this is where the 3 Fs are going to be helpful because it's usually one of these three aspects that's maybe been disrupted. It could be that, in the example of traveling, like you're grabbing on the go meals that are lower fiber than usual. You're avoiding fluids because you don't want to be the person getting up from the middle plane seat and going to use the lavatory. Your, exercise routine is disrupted. All of those are kind of easy places to shore things up and kind of revert back to normal. But for people who have chronic constipation, we're generally needing to start at the next rung of the ladder. And so typically this begins with osmotic laxatives. Osmotic laxatives work by pulling a little bit of water into the GI tract to kind of nudge things along. So typically you're going to see use of polyethylene glycol, which is Miralax. You might see high doses of magnesium supplementation. And all of this is, to try to both increase the frequency of bowel movements and potentially because of that osmotic mechanism, it may hydrate the stool. So if you have people with sort of those Bristol 1s and 2s that are very hard and difficult to pass, an osmotic laxative is a great first step because it may, in addition to helping people go a little bit more often, it may have the added benefit of sort of hydrating the stool, plumping it up and making it soft. Stimulant laxatives are a little bit different. They are sending sort of additional nerve impulses to the colon to contract and get things to move that way. So there's not really like a fluid shift that's happening there. Typically, the active ingredients that you're seeing are senicide and bisacodyl. So this might show up in products like Senecot, Dulcolax, X-Lax, things like that. In general, people can get a little bit nervous about the use of laxatives, especially when they're coming from kind of an eating disorder lens. There's sort of a paranoia that anybody with an eating disorder is really prone to overusing and sort of abusing these kinds of medications. As a note, we generally don't see that with osmotic laxatives. There are even some treatment centers where they may use that just because the rates of constipation are so high for people who have kind of restrictive eating behaviors. You're more likely to see misuse of laxatives with the stimulant laxatives. And this is where it is helpful to inquire a little bit about a client's history, asking like, have you heard of these medications? Have you used them before? What was that use like? Getting a sense of, have they gone overboard in the past where they were sort of exceeding what the package instructions were? Generally, we don't see any sort of poor outcomes coming from like using as intended, but there are case studies of pretty tough adverse events when folks are, maybe, taking 10, 20 more pills a day in sort of a effort to purge calories or sort of feel emptier. So if somebody has a history of stimulant laxative abuse, you may want to sort of tread with caution and also just ask them openly, like, do you feel like this is something that you could use as instructed, or would that be difficult for you? There are some clients who will say like, oh yeah, I did that once in high school, but like it didn't really stick as a behavior, and they feel confident that they could use that as instructed. And other people might say like, I don't know, I feel a little nervous about that. So it's always okay to sort of discuss that openly with clients. If we're finding that, osmotic laxatives and stimulant laxatives are offering some benefit, but just maybe not enough, then we really want to make sure that this person is set up with a gastroenterologist to perhaps trial some medications that were designed for IBS-C, or like a constipation dominant irritable bowel syndrome. I would warn clients like that it's a long process to kind of figure out what works. Often you're trying things and they work too much or not at all, or they stop working, and then you're layering on another one. It can take a bit of time to sort of figure out what that cocktail is that's going to be useful for somebody, very similar to psychotropic medications. If you observe that somebody is not even responding to osmotic laxatives or stimulant laxatives, like there's no increase in frequency of bowel movements, stool form is not changing, then that is a little hint that this person may need to be referred to a pelvic floor specialized physical therapist to assess for pelvic floor dysfunction, or what we would consider outlet dysfunction. Excuse me. Often in these cases, I will sort of describe to clients that, if the GI tract were a river, then motility, or like how fast things are moving, is sort of the current of the river. And, if we find that they're not responding to any of these laxatives, we're not convinced that the flow of the river, that there's anything wrong there, but that everything might be hitting a dam. If you have a dam in place, like nothing is sort of going to get through, at least in a sort of efficient and effective way that's going to allow them to feel fully empty. In terms of nutritional considerations, the most important message to get across is that in constipation, food is not driving the problem. It is either motility or some kind of outlet dysfunction that is driving the problem. And, what you eat is not going to change how tight your anal sphincter is, for example. That being said, there are some minor dietary changes that you may consider for certain folks. For example, if you're looking at their usual intake and there's like almost no fiber present, and there's constipation there, yeah, they may benefit from an increase in dietary fiber, just so that there's a little bit more of that GI motility that's stimulated. On the flip side, if they have huge intakes of dietary fiber and you're starting to pick up on all these signs that maybe there's a pelvic floor issue, you might actually want to scale back on fiber. To quote Kay Scarlatta, who's a GI dietitian based in Boston, adding fiber in these patients is like adding cars to a traffic jam. And so clients might feel mildly improved, or sort of like a little downtick in symptoms if we can pull some of the cars off the road, so to speak. A lot of clients who come in, they really want to know, like, what do I need to avoid to not have symptoms? And again, like in constipation, the food patterns can be a little bit all over the place, because it's really not about the food. It's about like, the stool burden that's already present, and, gas promotion within the GI tract, and all these other things that are sort of adding to pressure. But, something that you may point to if they need a tiny little thing to focus on that's not cutting out like a huge food group or source of nutrients is, you might steer them away from products that contain inulin or chicory root, or also sugar alcohols, just because those are such potent gas promoters. And typically there are lots of swaps that you can find when it comes to bars or beverages or even herbal teas, that don't have those things and aren't going to add to that gas burden. The third thing that we want to assess for is a possible food intolerance. And this comes after constipation because, when people are really backed up, sometimes they can have what looks like a food intolerance, and then they go regularly and suddenly they reintroduce those foods and it's fine. So if you're finding that like, bowel movements seem to be regular, complete, then we might, if symptoms are still present, we might ask ourselves like, was there a food thing that could be driving this? if you follow this particular algorithm, they just sort of jump to carbohydrate or FODMAP restriction and like gluten-free diet for, suspected gluten sensitivity. We may want to be a bit more careful, especially in folks where we're noticing there's already kind of a strained relationship with food or a noted eating disorder history. When it comes to elimination diets, like generally these are just straight up contraindicated for people with eating disorders. And this even includes the low FODMAP diet. And that's because we actually do have quite a bit of research showing that, you know, elimination diets further the risk of disordered eating and eating disorders. So for example, there was one study that looked at individuals with diet-related chronic health conditions. And so these were health conditions thought to be influenced by dietary factors. So for example, diabetes, IBS, et cetera. And in those individuals who were, sort of made to think more about their dietary choices all the time, there was an increased risk of developing disordered eating and eating disorders compared to healthy controls. For patients that were following the low FODMAP diet for IBS, having high dietary adherence, so being sort of like very locked in with like the demands of that diet, that actually, made them vulnerable to double the eating disorder risk. And furthermore, in a sort of GI setting, we saw that patients with a self-reported history of participating in some kind of exclusion diet were way more likely to meet criteria for ARFID, which is avoidant restrictive food intake disorder. And so all over their map, we're kind of seeing that there's this interplay between, cutting out foods, overthinking and overanalyzing food choices, and that sort of tying into disordered eating and eating disorder risk. So if you're going down the food intolerance route, I have a couple of tips for you. The first is you need to have a solid hypothesis. You need to have an idea of like what mechanism would be at play with this food to cause these symptoms on the timeline that the client is reporting. And those foods need to actually even show up in the person's diet. So many of our clients come to us after, maybe getting worked up by gastroenterologists or other providers. And I can't tell you how many times they say like, oh yeah, they just told me like, maybe I should do gluten-free, dairy-free. And I'm always like, based on what? We have to like make sure that there's a purpose to this, that there's like an idea that we're testing rather than just like throwing spaghetti against the wall and seeing what sticks. Because, each of these sort of eliminations are risky. They are not, without risk of harm. So another thought is, if you're sort of wondering about these big food eliminations, there are alternatives to that. So there are a lot of digestive enzyme products that are on the market that may allow you to sort of test that theory without pulling the food out entirely. So for example, lactase in the case of a suspected lactose intolerance would mean that that person can still have their latte, but sort of see like, are things better when I'm supplemented with this enzyme? Fodzyme is another great example of one of these products that actually brings a few different digestive enzymes kind of under one roof in one product so that people have a little bit more coverage for some of these foods that would otherwise bother them. Another alternative is to do what we call cherry picking, which is basically to pull out really a narrow select group of foods that you feel like are driving the majority of symptoms. So I'll give you an example. I had a client come to me a couple years ago. I knew her therapist, and the therapist was like, listen, my client's, got a long eating disorder history. She's got some GI issues going on. I told her she should talk to you. She does not want to work on her eating disorder, but she does want to sort of understand what's going on from a digestive perspective. So we met, and she was reporting a lot of bloating and gas. It sort of had like a later onset later in the day. Constipation, those symptoms did not really match up with sort of like symptoms and reported bowel movements. And so taking a closer look at the diet, I noticed that she had a little bit of an orthorexic slant, a little bit of like a low carb slant to her intake. And so she had all the different cauliflower products in her diet. She had cauliflower rice and cauliflower crust pizza. And I think Trader Joe's had a cauliflower gnocchi at the time. And based on sort of like the days that she ate those and the timings of symptoms, it seemed really prudent to perhaps just pull that out and swap for some other food products or some other starches. And so that's an example of like, we cut something out, but it was like a single food and wasn't sort of this broad category that's going to um, disrupt like her nutrient status and sort of in line with the last line on this slide, we talked about alternatives. You don't want to take food away from somebody and then just not leave them with swaps and options to replace that with, because clients, you know, it's not uncommon for them to kind of like lose that spark of creativity with meals, and like you take something away and they just don't fill in that vacuum with anything else. And then suddenly, they're eating less and less. So anytime that we are making swaps, or excuse me, potentially pulling things out of the diet, we want to make sure that swaps are available to that person. The next condition we're going to talk about is SIBO. And I'm going to hand it over to Jordan.
Yeah. Um, I think one of the things I just want to make a quick point with constipation too that is helpful sometimes is I will often ask patients, because for most people, if you ask, even if it's just once in the last like month, did you ever have like a really good poop where you're like, that was amazing? And if the answer is no, then we have some work to do on sorting out their constipation. But for many patients, it's not 100% of the time that they're constipated. And if they have a good, complete evacuation, I will ask, does your bloating and distension feel better? For a long time, we didn't know that pelvic floor disorder related constipation, if we fixed it, it helped with upper GI symptoms and bloating and distension. A few years ago, we started to have studies emerge showing that even though we'll often kind of break it into like, different parts of the GI tract we're focusing on, many of those patients, if we can fix their constipation, it gets better. And that's often a question that's a good hook to get them. They're thinking everything is up here to say, let's actually focus on the constipation, because now we have data showing that it does improve things. So SIBO, small intestinal bacterial overgrowth and intestinal methanogen overgrowth, or IMO. Similar conditions, just different bugs. In SIBO, it's a variety of different. It's not a specific bacteria, so this is not an infection. This is just an overgrowth of bacteria and certain types of them. In IMO, which will go through kind of why we try to sort this out. It's technically archaea, or a type of a bug that tends to produce more methane. So in classic SIBO, you can imagine if there's an overabundance of bacteria, everything that goes in is going to get fermented like normal. It's a normal thing. And in the small bowel, I will often explain to patients, the colon has tons of bacteria and it's a very large diameter. And those bacteria do things for us. They make certain vitamins, they make short chain fatty acids for colonic cell food source. There's a ton of processes going on, but there's room for them to like ferment and make gas and not feel it as much. The small bowel is a much narrower diameter. It's 15 to 20 feet long in most adults. And so you can imagine like a little bit of extra gas production can be very uncomfortable. And so the classic, when you read about SIBO 15 years ago, 20 years ago, it was somebody who had post-surgical anatomy. There was something that disrupted the normal flow through their bowel. They had a stricture from Crohn's disease. They had a piece of bowel taken out, like the beginning of the colon and the end of the small bowel. There's an ileocecal valve that prevents colonic amounts of bacteria from getting into the small intestine. And those types of things, had to be present for SIBO to happen. And it was initially sort of written about as this. There's a ton of overgrowth. There's malabsorption because there's biofilms kind of coating the bowel and you can't absorb things. And it's a lot of like steatorrhea or fatty stools and malabsorption of some nutrients. More recently, it's sort of shifted to this like with the advent of easier to access breath testing that a lot of patients, even without those things, can develop SIBO for a variety. It might be post-infectious, they get a stomach bug and they just never recover. Could be related to a motility disorder or underlying neuromuscular disorder like scleroderma. So there's a whole bunch of ways, but the common final pathway is there's more bacteria than there should be, and they're producing more gas than normal. So the gold standard for this is to do an upper endoscopy a little deeper than we go with a standard endoscopy from above. Or you may have heard the term EGD or esophagogastroduodenoscopy, which is why we call it EGD and don't say that. But you can go into the upper, small bowel into the jejunum and aspirate some fluid and send it off for culture. And there are cutoffs that vary a little bit depending on who you read as to what constitutes an abnormally high bacterial count. The more common thing that we'll do, because it's less invasive and it's easier to access, are breath tests, where we give we have somebody do a baseline breath. We give them a carbohydrate substrate, usually glucose, or sometimes lactulose, and then we measure at 90 minutes a series of gases. There are different companies out there, different tests. Some traditionally only measured hydrogen. Most of them now will do hydrogen and methane, and then there's at least one on the market that will do hydrogen, methane, and hydrogen sulfide. The reason that's important if it's just hydrogen that's overproduced, we'll usually do a 2-week course of an antibiotic called rifaximin or Xifaxan, which is a gut-specific antibiotic. It has very minimal absorption into the body, and it kind of hits a reset to this overgrowth of bacteria. The goal, obviously, being ideally if we can find an underlying cause of someone's SIBO, which there are a multitude of, then we have a little bit better chance that we treat them, they get better, and they stay better. There are patients who need cycles of antibiotics, though. IMO, when somebody is overproducing methane, we'll treat with the same drug plus neomycin, which is another fairly minimally absorbed older antibiotic because that has a little better efficacy against that, the archaea that produce methane. And we see IMO a bit more in patients who are constipated. Like so many things in medicine, whether it's a chicken or egg, we don't know. What has been identified is if you instill methane into colon in a lab, it does slow motility. But we also see patients where like they have pelvic floor issues and it's not, they just build up bacteria and they end up having more methane. So it's not that 100% of them, like the methane is the bad actor, but it alone can slow motility. So we treat with both. And then we add on Pepto-Bismol, bismuth subsalicylate for hydrogen sulfide. I will say this is something that's just like everywhere. There's forums where you can find people where it's like the treatment for this is, in the functional medicine world, 6 months of cutting out a bunch of food, repopulating with probiotics, which has no evidence whatsoever, and then doing these like 6 to 12-month programs, which I have a lot of problem with just because they're not backed by data. But SIBO has kind of become this whole other, which I'm sure in this setting, many of people are aware of this, has become this thing where there are practices where like everything is SIBO's fault. And so that's something we're always kind of battling against too.
Mhm. Yeah, if you were to look at, PubMed studies just using sort of the term SIBO, you'll see sort of like a flat line, meaning like no studies, and then just this explosion in probably the last 10 years. And so, I wouldn't be surprised if in time we maybe have some adjunct therapies to add on to the antibiotics, but everybody here should know that there is not strong evidence to support anything besides the antibiotics right now. So after SIBO, then we might be thinking about something called abdominal phrenic dyssynergia, which goes by APD, or visceral hypersensitivity. And I'll let Jordan talk a little bit about that.
Yeah, this is kind of a newer entity where a lot of patients with bloating and distension, we've known for a couple of decades that you can do CT scans or CAT scans of these patients, and they don't have more gas. It may be segmented in different areas or trapped in certain areas, or they may just have normal amounts of air on the CAT scan, but have hypersensitivity to that. Abdominal phrenic dysenergia is this pathological contraction and descent of the diaphragm, which normally when that happens, there's a slight, if you have like EMGs on people's abdomens, which measures like muscle activity, when the diaphragm descends, there's a normal, which is what happens when we take a breath in, makes air in the lungs, and there's a little bit of contraction of the abdominal muscles. And in some patients, there's instead a relaxation and things just protrude their abdominal, wall and contents. It's softer. And so this is kind of it's a tough entity to explain to patients. There's not a standardized test for it. And I think we often think about this in patients where we've gone through all the other potential, we've gone through food sources, medication, we've tested for SIBO and IMO, we've maybe trialed the medication for visceral hypersensitivity to just kind of tamp down how sensitive they are to maybe normal amounts of gas and bowel contents. We've managed the constipation, we still, are struggling. And so the treatment for this is in an ideal setting, EMG, which is electromyography, biofeedback, where they have sensors measuring muscle activity. That's rare to find, and that's usually done with diaphragmatic breathing, and then treating any other associated disorders of gut-brain interaction, like irritable bowel syndrome or functional dyspepsia. So this is kind of a newer entity. And I think it's still evolving to kind of understand like the proportions of patients with bloating who have this. But I think in a lot of these patients, we've already had the discussion of dysenergic defecation, which is the most common type of pelvic floor dysfunction causing constipation, which is just, it's a normal reflex that just stops functioning or gets a little clumsy, as I'll say. And so when somebody's trying to push and poop and those muscles, instead of relaxing, tighten or don't relax, we've often already had that discussion. So just moving up a little bit and talking to them about a similar thing happening where the dysenergia is just they're out of coordination compared to normal. So.
Mhm. And something that you might sometimes hear from people that are experiencing this is, often if there's like constipation or, something that is sort of filling the belly, clients will describe their abdomen feeling like really sort of taut, like stretched by something that's sort of pushing out from the inside. Sometimes with APD, you might hear more mention of like it just kind of sort of feels like everything went slack in the front and everything's just kind of like hanging out. And that sort of speaks to just like that kind of inappropriate relaxation of the abdominal wall that lets everything kind of like protrude. You might also hear mention of like, I could drink water and might look, like I'm in my second trimester of pregnancy. So sometimes that's a little bit of a tell as well. When Jordan and I were writing the textbook with other clinicians, to be quite honest, like we did not find, tried and true evidence-based nutrition strategies for these populations. There just aren't studies that exist yet. That's sort of the status of a lot of different GI conditions, like more studies needed. But if we were to sort of use our best guess of what is going to be helpful for our clients, we end up with a couple of strategies that are worth exploring. So I say all that just to add the caveat of like, you're not going to find studies supporting this. This is just sort of clinically what we've found to be helpful and like open to changing my opinion if any studies emerge. But because often visceral hypersensitivity and APD are sort of triggered by like kind of a inappropriate body response to stretch, one being sort of like muscle laxity, another being like sort of intense kind of like pain communication along those brain pathways. Often these folks are going to do better with small, frequent meals. You're trying to kind of minimize stomach stretch to sort of lessen the downstream effects of how that's going to feel for people. So rather than 3 square meals a day, these folks are probably going to do better with like 5 or 6 small meals. It's also important to consider texture modifications so that like you're also addressing the volume that may contribute to more of that stretch, or even like slowed gastric emptying that's going to sort of make things kind of sit and apply that pressure for longer. So sometimes you'll hear this referred to as like a low roughage diet. Tamara Jacob-Freuman refers to it as a GI gentle diet in her book, The Bloated Belly Whisperer. But basically, like we're taking some of the bulkiest fiber sources that would slow down digestion and be very bulky, and we're trying to sort of modify those through peeling and de-seeding foods, through blenderizing things, through cooking them really well until they're fork tender. And also it's important to encourage clients to like slow down, chew their food well. So for example, folks with these conditions, they might not feel that great with like a raw kale salad with, blackberries and slivered almonds. But they may do much better with, say, one of those like, roasted beet and citrus salads with some goat cheese and a couple of walnuts. So we're kind of in a position to help them translate, like, what is still going to be a fiber containing diet, but like perhaps in a texture that's a little bit better tolerated. Another consideration for these folks is to make sure that like more of their fluids are not taken in at the same time of meals, just because that's adding to volume, that's adding to that overall sort of stretch, and is more likely to trigger symptoms for them. So that is going through the AGA algorithm for treatment of abdominal bloating and distension. We have a number of references that you'll be able to find on your slide, and all of those are sort of linked to on each individual slide, so you can see what those are referring to throughout the presentation. But happy to take any questions if those have come up.
Fantastic. Thank you guys for such an amazing presentation. To everyone out there on our webinar, I just sent into the chat a link to download your CEU certificate. If you have any trouble accessing it, just let me know. And with that, yeah, let's dive into some of these great questions. So, starting with Melissa's question asking, what if your client has gone overboard in the past with osmotic laxatives? I know you mentioned this is rare, but potentially also seen.
I mean, I think it's worth inquiring, like, how do they feel about them now? Like, it's sort of a question mark. Like, was this 2 months ago? Was this 15 years ago? How do they feel about trying them now? And does that feel like it endangers their eating disorder recovery? If those aren't an option, then we may need to sort of bring a gastroenterologist in a bit sooner to try out some of those different like secretagogue medications. So, when there's a barrier in the road, then we're going to drive around it.
Okay, great, thank you.
I think
Here,
I would just say, I think the other thing is just giving permission, like not shaming. I'll just say, one of the things that some patients find difficult is that there becomes this temptation, and will you just, I want to get you better, but I want you to have an open line of communication. So I've done things like put feeding tubes in patients who've never purged in their life, and they start purging. But the patient told me, and we had to take it out because it was all of a sudden this new thing. So um, that's it.
Yeah, that's a great point. Like, there are some people that might feel open to trying it, but like let's really stay in touch. And if you feel like this is going a bad direction, let me know. Same as we would for like food logging. Some people have a very precarious relationship with that, and they might be willing to start it, but then they might come back to you and be like, this is not good for my mental health. And so we work around it.
getting back to our questions here on a similar vein, Sarah asks, I noticed that in treating constipation, the referral to GI is at the top. Are you recommending RDs should recommend the osmotic or stimulant laxatives, or is this managed by a PCP or someone else? I have a hard time figuring out my scope here as an RD and what is appropriate.
I mean, scope of practice is in part determined by your experience and your knowledge base. So if you sort of understand how to use these, like then you could recommend them in your practice, especially because we're talking about over-the-counter products that clients can get at CVS, at Walgreens, on Amazon. And, for especially for a lot of people who are maybe trying to get in with a specialist, like it could be a long time. And like it's worthwhile to, try a few things for relief in the meantime. So I don't have any issue with using these in my practice, but I think if you're um, sort of not sure how like the dosing works, then maybe seek out a little bit of extra information about that, just so that you know what to tell people, what they should expect, when they should sort of understand that like maybe it's not working and they need to circle back and you can sort of change your approach. Is there anything you'd add to that, Jordan?
No, I don't have any problem. I mean, I think in a lot of places the time to get into someone is long, and I always it's information to me if somebody's done Miralax like 17 grams, which is just a capful and 8 ounces of water daily for a couple weeks or a month before they see me, and that's helping or not helping. It's another data point for me to start with. So yeah.
Great. Here, a question from Lauren. Where does stress and trauma come in for constipation? If you're able to speak to it.
Yeah, I mean, my practice has become a lot of like fourth, fifth opinion people with really heavy trauma histories. I think we've known like the epidemiologic nerdy answer is like we've known for a long time that with a lot of disorders of gut-brain interaction, which includes things like irritable bowel syndrome with constipation, that a history of trauma. A lot of the studies are looking at like early life adverse event, childhood events, or ACEs or the history of sexual trauma. Just having that alone, even if it wasn't like trauma that involved that area, can certainly impact it. The risk of having those. And we think that it has something to do with just the gut brain nervous system connection. Um, People feel stressed and anxious and they feel things in their gut. Um, and that's just one of the places that I think the body, sort of keeps the score in the gut. Specifically with one of the most overlooked causes of constipation in those patients, which is like dysynergic defecation and the pelvic floor stuff. It's a really it's a delicate thing to investigate with patients. I will have to tell them, typically if you've tried a medication and it hasn't worked, like I do rectal exams on patients, but I will specifically give them permission to pass on it, to hold off on it, to have a female pelvic floor physical therapist do it because a lot of GI doctors don't do them, especially for evaluation of pelvic floor muscles. But I think that's often an opportunity to explain why we're asking about trauma because there can be this link and it may actually impact if I just go straight for rectal exam, like that could re-traumatize somebody really horrendously. And so in my practice, I just have a conversation. I say, like, this is why I'm asking this sensitive question, because I want to make sure that the care I provide to you is sensitive to the experiences you've had. I don't know if that helps.
Yeah, and I think just something that I would add to that is, if we think about nervous system regulation and kind of like moving into different nervous system states, like fight or flight, there's this whole cascade of physiological reactions to that shift. Like you have more rapid heart rate and breathing, blood pressure changes, like all these different things in the body are changing. And it makes sense that there may be aspects of digestion that are impacted as well. So, whether it's, trauma that involves like flashbacks, or perhaps you're working through that actively in therapy and everything's very heightened, or even just toxic stress from being, in a job that doesn't appreciate you, like all of that can sort of trickle down to GI impacts. It's just hard to know exactly how it's going to do that in each individual.
Fantastic. Thank you both. Here, we have a question from Madeline. For clients with pelvic floor dysfunction, while they are seeking a pelvic floor physiotherapist, do they often also need other lines of therapy at the same time, or as some improvements occur, like a stimulant laxative or osmotic laxative to relieve the constipation?
Yeah. I think look, one of the things I would say is so, I mean, normally you have two sphincters, the internal, the external. The internal one is completely reflex driven. So it's closed at baseline, thank God. So we're not walking around pooping on ourselves. And what's supposed to happen when the rectum fills with stool, the last part of the colon, it dumps stool into the rectum. And that stretch gives us the urge to go, and it relaxes the internal anal sphincter. And we have control. Like if you do a Kegel or like squeeze your anus right now, that's the external muscle, anal sphincter. It's just like a biceps muscle. Like you can say, I'm going to squeeze my muscle. You can do it there. You hold until you get to a restroom, and then you relax it and pass the stool by generating just a little bit of intra-abdominal pressure. So when those things get out of order, there may or may not be a sensation issue where people don't feel a normal amount of stool in the rectum. Um, I say I'm giving you all this background just because some of the things that we might say as a first line for somebody with like general constipation, like try, if you're not eating enough fiber, add like a fiber supplement, bulk the stool up and just make more stool for those kind of clumsy and discoordinated muscles to work with. And so that can make bloating and constipation worse in patients with pelvic floor disorders. I think while they're waiting, it doesn't hurt to try those. I'll just let them know if you feel like you're doing this and it either tips you from constipation into like, oh, great, I'm going, but now I have like diarrhea, or it makes you feel more bloated because you can't relax to evacuate, then just back off. It's not going to cause harm, aside from those symptoms. One of the things that 1 in 6 patients do get better with dysynergic defecation, which is just the most common pelvic floor disorder, there's a bunch of different ones that can happen, is a squatty potty. So I will often say, en route to the pelvic floor PT, you can try a medicine, maybe caution with fiber specifically, but try a squatty potty because 1 in 6 isn't amazing, but 1 in 6 patients in a study that was done at the University of Michigan with Bill Che, like that completely relieved their. So that's an easy win. And if they can't get a squatty potty, stack some books. I always just tell them, like, for harm reduction, sit down first and then put your feet up. I don't want them standing on a stool and like falling and breaking a hip or something. So
Yeah, I would add to that. Yeah, mileage will definitely vary with some of those laxative products with pelvic floor dysfunction. Some people will respond a little better to the stimulants, just because that is sort of creating a little bit more of like a muscular change rather than just like building up pressure to sort of blow past that back door. So yeah, I try to look at like how many different nudges can we line up to sort of hit at the same time. So maybe that's the squatty potty and sort of like correct posture, like Jordan was saying. Maybe that's a laxative that was in the evening so that hopefully like you have a more productive bowel movement in the morning. Maybe that's coffee for people who enjoy it. Maybe that's a bigger breakfast to sort of stimulate more motility. Maybe that's even considering something like a glycerin suppository later in the day if they find that that pressure is just like really building up. But yeah, we have kind of like a bunch of little things that might help a little bit each, and not a lot of great options until some of that muscle lack of coordination is addressed.
Thank you guys. Great. Here from Nicole, is there a concern of the body making less of its own digestive enzymes when we supplement with enzymes often?
No.
Can you speak about probiotics' role, if any? I imagine this is a very common one. A lot of people out there here.
we're not allowed to just say no. I mean, this is what I would say. I mean, we peddled these for a long time, for 20, 30 years, as like the panacea, right? Like just sprinkle some good ones in. And then it became, evident that this is a whole ecosystem that we're trying to nudge back towards normality. And our ability to do that in a given person and to say this probiotic for these symptoms for this long at this dose will give us this expected outcome X% of the time, is almost impossible for the majority of the major reasons that people use them, which more often than not is symptoms more than even a bona fide diagnosis of like irritable bowel syndrome. And so the challenge is, like, in the US, I mean, there's 50 plus studies of these for IBS, and there's some that with positive direction, like positive outcomes. I think it's just really sloppy right now. So the AGA 2020 put out a guideline saying, including for IBS, for most conditions, don't recommend them outside of a clinical trial. The Brits, the UK guidelines for IBS were a little bit more lax and said, listen, it's messy, no doubt. Let's just be transparent. But the risk of harm is generally pretty low. There's tons of caveats to all this, but it's pretty minimal. And try for up to 12 weeks. But there's no data supporting somebody needs to be on a probiotic for like 10 years. So my personal practice is I will have that conversation. I will say, I want to protect your pocketbooks. I can't tell you that the $400 designer one is any better for you. If you're really inclined to try it, I'm open to you trying it for a discrete amount of time. If you've been on it for 10 years, I would encourage you to stop it and see, do you still need it? Because you may have nudged this ecosystem and caused this ripple effect and may not need it. It's a rare person who starts it, gets better, stops it, gets worse, and gets back on it and is like, oh, I'm better again. I can't say it never happens, but not in a consistent enough way to widely recommend them.
Thank you, guys. And here we'll wrap up with one question on SIBO. I wish we could get to everyone's questions. They're all fabulous, but we're just limited on time. So here, Sharon asks, does SIBO develop more often in patients with hypochloremia? It seems to reason that the low stomach acid with so many people on PPIs may lead to poorly digested food that may be fermenting in the gut. Any comment on stomach acid related to SIBO?
Sure. Um, I would say the answer, if you look at the SIBO guidelines, and there's so many now that are coming out, but I think within the last few years, there is data that it's about a 6 times increased risk of SIBO with being on proton pump inhibitors. That includes things like, to avoid brand names, things like omeprazole, pantoprazole, rabeprazole. Um, does it happen that often? No. You look at how many people are on these. It's one of the most common prescribed and over-the-counter used drugs. I think it's, if anything, in these patients, like if somebody's had a significant risk of SIBO or they've had a history of SIBO and they're on these, we don't question enough with a lot of medicines, including these acid suppressing medicines. Do you still need it? And so there's been a lot of encouragement to try to taper people, at least to lower doses. I think we definitely have patients where we get caught in jail, where we're like, you need this because you have Barrett's esophagus, but also you have really bad SIBO, and how do we get you out of this, like, this situation that we're in, where we just keep kind of going through the same cycle. So that does happen, and that can be challenging. But the short answer is yes, there is an increased risk, whether it's from a PPI or in patients as well who have like chronic atrophic gastritis, and those acid-making glands in the stomach just get destroyed, or autoimmune gastritis. We do see increased risks of and rates of SIBO in those patients.
Great. Well, this has been incredibly helpful. Thank you all for coming on here to listen to our experts, Emily and Jordan. I know I've learned a ton. As I mentioned, you all will receive an email with a link to the recording, and I'm here to support you with any needs you have around the CU certificate. I know it can be tricky sometimes with these internets getting blocked in certain networks. So thank you both again for coming on. And with that, our webinar is coming to an end. Thanks, everyone.
Thanks so much for having us.
Thank you.